Thank you. Thank you all once again, and may I reiterate the expressions of thanks that were conveyed to Dr. Wase for a very inspiring and thought-provoking presentation, as well as to all my colleagues, I think, who engaged with very pertinent points, and in some way, actually, I think also served as an important introduction, if you will, to my next presentation. I have this introductory slide perhaps as way of apology, as we've discussed some very cutting-edge approaches to dealing with certain syndromes today. And one might argue that the topic of discussion is somewhat mundane. However, I hope that you will see that it fits very much in with our very recent discussions about harmonization of stroke care, as well as a tailored approach, as was alluded to. So to set the stage for this discussion, I'm going to share two introductory cases with you all. The first case was a young woman who was admitted to one of our hospitals for a femoral embolectomy. She had a known history of a mechanical mitral valve replacement, and thus, while she was in hospital awaiting her procedure, she was on a unfractionated heparin drip. She was noted in the evening of her stay to have an apparent weakness of her left lower and upper extremity. This was brought to the attention of the charge nurse and noted, documented, however not discussed with the most responsible physician until the following morning, where then subsequently the stroke team was alerted. Imaging by this time demonstrated a completed stroke in the right frontoparietal area. Not really much we could do here. However, as a testimony to the plasticity of a young brain, reassuringly, the patient did well. She was transferred from the vascular surgery unit to the stroke unit for ongoing inpatient rehabilitation, and actually did rather well. A fortuitous and providential outcome. In the second case, it was an elderly gentleman who was post-operative day 1 after a carotid endarterectomy. He presented with an acute left hemiplegia and hemi-neglect syndrome, and this was identified at approximately 5 hours. Now, I'll be dating myself here because this case actually occurred while our center was still enrolling into IMS 1. And so we really had to twist the arm of our interventionalists at that time for endovascular approaches. And in this case, the patient was treated conservatively. But I think these two cases, I think they nicely represent some important characteristics of the patients that we will encounter that experience their first event in hospital. Both of these patients, you'll see, had undergone high-risk procedures for periprocedural stroke. They had an inherent preoperative risk that was high for in-hospital or perioperative stroke. Despite this, you can see that there was an evident delay both in time to symptom recognition as well as communication and mobilization of resources. And you'll also see that both of these patients had contraindications to intravenous thrombolysis. Now, it was this type of experience that prompted us to participate in a provincial quality care protocol, piggybacked, if you will, onto a much more prominently discussed and published initiative that impacted our door-to-needle times for strokes presenting to the emergency room from the community, the proverbial out-of-hospital stroke. And working with our network, we, if you will, recruited a few centers that were interested in tackling this issue of in-hospital stroke and addressing quality improvement metrics for this unique population that ironically, while presenting underneath our noses in hospital, are distinguished by having what the literature would appear to suggest poorer outcomes in terms of mortality as well as functional outcome. It is a sense of great frustration to me and irony to be aware of the fact that the hospital is often the worst place to have a stroke. The literature would suggest that patients who will experience their stroke in-house will actually have a higher mortality, indeed up to almost twice of that seen in North America. A fewer proportion of these patients will receive acute stroke interventions. However, when we look at the proportion of patients that do receive acute stroke interventions, notwithstanding the postulated role of the comorbidities that have brought them to hospital, they all seem to be doing just as well as patients who receive it in the community. Suggesting that if we can increase the proportion of patients in-house that will receive acute stroke interventions, we can markedly impact outcome in this subpopulation. So there were, in fact, 2 sites that participated in this program in our province. One was the hospital that I was at the time, and the other were our colleagues at another hospital in central Alberta. And we shared data, and with response to the recommendation to tailor treatments, perhaps in some small way this aspiration to address issues of inpatient stroke speaks to that harmonization is not an issue of dogmatic adherence to certain protocols, but rather an individualization of logistics that prevail in different settings towards a shared goal of improving outcomes. Now, this protocol occurred over 2015 to 2017. And some of the preliminary patient characteristics that we found did parallel what is seen in the literature about in-hospital stroke, whereas we saw certain high-risk services and diagnoses to hospital as being represented for those patients that are at risk of presenting with in-hospital stroke. Also clarifying the venues that are high risk, like the coronary care unit or the vascular surgery unit. Most of in-hospital stroke will actually occur within the first 72 hours. People who are admitted to hospital and destined to have their first stroke, most of them occur in that first 72 hours. And who first recognizes it? Well, as you would infer, it is most commonly the nursing staff, followed by the medical staff, and then an important and often underappreciated resource is that of family members, who will tell you when they think that something is amiss. So the aim of this was to first establish baseline metrics for in-hospital stroke across these sites, and then subsequently come up with tailored protocols for contending with in-hospital stroke and ascertaining if this did indeed increase the proportion of patients that received acute stroke interventions. Our strategies could be broken down towards developing a site-based in-hospital stroke protocol, and for convenience of discussion, I'd like to think of it as breaking it down into 3 phases. That is, when you are envisioning your protocol and recruiting stakeholders and collaborating towards building one, phase 1 is one of communication, in which the protocols establish who to contact and how, and clearly elucidate what information needs to be communicated. Phase 2 is that of establishing protocols for patient transport. Now, obviously, geography will vary from site to site. The locations of imaging and how strategically placed your patients are in high-risk areas, all these factors will vary from venue to venue and will require, of course, idiosyncratic planning. And then, of course, the third phase is developing your treatment phase for the patient. And of course, this will pay testimony to the logistics as they exist at your individual site. But I think as a rule of thumb, my observation has been is that it is best to try to capitalize on the pathways that you have established for contending with your strokes when they present to the emergency room. Allowing this to intersect with your protocol for in-hospital stroke does prove to be very beneficial and reassure a lot of the apprehensions amongst other stakeholders who are gatekeepers for important resources like monitored beds, for example. And so what was the impact? Well, essentially what we saw was there was certainly an increase in the number of in-hospital stroke codes that were called in that time frame. The time to alerting the neurologist was improved. The number of acute stroke interventions that occurred both in the ward setting and the emergency room setting had increased in terms of the number of patients who both received TPA as well as endovascular therapy. And of note, both of these centers transported out in a drip and ship model 4 patients who were candidates for EVT, and the symptom onset to departure time, I would say, is quite competitive for an in-hospital presentation at the time. Of course, our treatment targets are growing increasingly more aggressive. So you can see that over that time frame at these 2 hospitals, the number of patients that received acute stroke interventions, modest, and a reflection of the fact that in-hospital stroke will really only ever represent 10% of the total burden of strokes in hospital. Fair enough. But the solutions that you implement, this is perhaps the proverbial resource-neutral solution. You're utilizing expertise, protocols, and pathways that exist and can make an important impact with a relatively small investment. Now, for what it's worth, amongst our small numbers, we did see a marked improvement or a discrepancy between the modified Rankin score between those patients who received acute interventions versus those who didn't. And this slide I find unsettling because though it did indicate an increase in in-hospital strokes that were identified over the period of study, this was certainly not commensurate with any ambient changes in volumes or in practice patterns over that time frame. And so in-hospital stroke, to my mind, what concerns me is that it still remains the proverbial tree in the forest that nobody is listening to. And there is going to be a proportion of patients, I would suspect, who are being discharged from hospital with significant disability and comorbidities that have remained unidentified. So as an epilogue, I'm going to share 2 cases, seen actually very recently. In this first case, the patient was post-CABG and was noted to be complaining of vertigo. Thus, the stroke team was not alerted, but rather the general neurology consult team. And on examination, focal findings were determined and an urgent CT scan was obtained. There was some glimmer of some posterior fossa changes, and so an urgent MRI was obtained on the same day, which demonstrated bilateral cerebellar acute infarcts. Now, this patient is unfortunately not a candidate for an acute intervention. CT angiography was done to reassure ourselves that there was no basilar thrombosis. However, the patient was relocated to the ICU, monitored closely for any signs of posterior brainstem compression, and ultimately did undergo surgical intervention. And I recently followed him up in clinic, actually, with good recovery. Second patient was admitted to an internal medicine service with Pseudomonas bacteremia and was presenting with 3 days of what was felt to be delirium. A CT scan was done as an afterthought, which demonstrated subacute multifocal stroke, and the MRI, as you can see, demonstrated actually a much more diffuse pattern of embolic-type lesions. The patient was actually determined to actually have aortic vegetation, did undergo valve replacement, and had a very good neurologic and systemic outcome. I recently followed up in clinic. So I use these two cases to point out that the impact that we can have on recognizing in-hospital stroke in a timely fashion goes beyond merely identifying those patients who will receive acute stroke interventions. We will make an impact in outcomes even beyond reperfusion strategies if the challenges for the protein manifestations of in-hospital stroke due to comorbidities, co-medications, etc., are surmounted in part by educational strategies and targeting the stakeholders. So I'm going to end actually with suggesting a platform for collaboration. My email is right here. If there are any centers that do want to work towards collaborating on improving outcomes on in-hospital stroke, please do contact me. I would be happy to share experiences and collaborate in the future. Thank you.